All right, good morning, everyone. It is incredible to see all of you here early after what I hope was a fun Saturday evening. I'm going to start with a story. So my first attending job was at The Ohio State University, and a couple weeks into being an attending, I was doing a thoracic case, had the patient positioned lateral, double lumen tube went in easily, we had lung isolation, I sent the resident for a break, and I noticed the patient was getting a little hypotensive. So I gave a little phenylephrine, I went up on the phenylephrine infusion, and then I noticed the blood pressure didn't get any better. So then I made sure that the resident had connected the phenylephrine infusion, which it was connected. I gave some more phenylephrine, and then I noticed now the patient is more hypotensive and bradycardic, and things are looking bad. And the reason I bring up this case is this is what we're going to talk about today, is perioperative resuscitation and life support. And these are the cases that sneak up on all of us, that are hard to manage. This is some data from the UK, the NAP7 project that just got published recently, and 70% of practicing anesthesiologists said they would like more training in the management of intraoperative cardiac arrest. And so my name is David Stahl. I am a clinical professor at Stanford, and we're going to be talking about perioperative resuscitation and life support. My disclosure is that I am on the editorial board of the ASA PeRLS product. I'm going to talk about it. I believe in it. I've helped develop it, and I think it provides an incredible educational opportunity. We'll come back to that. The product itself you can find on the ASA website at asahq.org/PeRLS. You can use the QR code here. And the reason that we built this product is to create an opportunity to provide streamlined, specialized cardiac life support training, and recognize that what we do in management of perioperative life support is different than what most of ACLS teaches. And so this hopefully addresses that educational need. And in this talk today, we're going to do three things. First, we're going to talk a little bit about why perioperative arrests are different than what we see in definitely our in-hospital cardiac arrests, and of course our out-of-hospital cardiac arrests. We'll talk about some of the rare and more kind of complex pre-arrest crises where, like this thoracic case, where you see the train is going in the wrong direction and you want to ideally stop it before you get there. And then we'll talk about how do we use some of the PeRLS tools, including some of the algorithms, to talk about the management of these patients in the operating room and around the perioperative period. I am going to use the audience response system a little bit to keep you all awake. You can get there three ways. You can use the QR code. You can type in that website into a browser, anes25.cnf.io, or in the meeting app, if you go to this session and just click on the QA polling area, it will open up for you. I'll give you a minute to join. We won't be tracking your answers, I promise. If you go to your schedule and you go to this session, then you'll see a QA polling button on that session. All right, little quiz. When was CPR first described? Oh, we have a battle. No, I'm talking about closed chest CPR. All right, I like some tension here. So the correct answer is 1960. CPR was first described in 1960, defibrillation 2 years later. The first ACLS algorithm was published now 60 years ago in 1966. And the two most recent updates from the AHA came out in 2020 and then a focused update in 2023. And for PeRLS, this started as the anesthesia-specific ACLS in 2018. It became PeRLS in name in 2022. We launched the certificate program in 2024 and then a physical resuscitation module this year to kind of address some of the concerns around providing both basic life support training as well as advanced life support training. These are some of the faculty who have worked on this project over the years, definitely not an inclusive list. I do want to call out Drs. Moitra and O'Connor. as well as Dr. Ben Jacob and Dr. Nunnally, because they have all contributed to these slides in this project and my ability to give this lecture today. So back to the case. This is a patient, for those who came in a little bit later, a thoracic case, lateral, lung isolation, worsening hypotension, not responsive to phenylephrine, and now bradycardia. And I think this case highlights the challenge of ACLS, because when you look at the ACLS guidelines, there's nothing there that really helps you in the management of this patient. Like, you could go to the symptomatic bradycardia algorithm, but the patient was hypotensive before they were bradycardic, so I don't know if that's the right place to be. You could go to the ACLS algorithm, but again, hopefully you're not going to get to doing chest compressions in this thoracic case. And so I'm going to talk a little bit about why I think PeRLS and ACLS are different. And I think they're different in fundamentally 3 ways. And I'm going to use these icons a little bit through the talk and talk about the differences. But the first is that PeRLS challenges you to think while you're acting. And I think that is something that as anesthesiologists we do all the time. We see hypoxia, we turn the FiO2 up to 100%, we increase our flows, we manually ventilate, and we're thinking about the differential diagnosis for the hypoxia. And PeRLS builds that into all the algorithms, whereas most of what the AHA does is tell you, you should do this, you should do this, you should do this. And along with the doing icon here, PeRLS, we've tried to build things into a flow-based algorithm. I think many of us have an engineering mindset, and we like to see one thing move into another thing, move into another thing, as opposed to just a series of recommendations, which is predominantly how ACLS is presented. And then the final difference between them is here in the middle, which is that hopefully none of us are anesthesiologists who are really good at running intraoperative codes. Hopefully we're all anesthesiologists who are good at preventing intraoperative codes. And PeRLS allows us an opportunity to think about what can we do to prevent an arrest before the patient gets to that phase. So I want to give 2 example cases of where I think these differences are highlighted. So the first is a case where you're called to the emergency room to help. This is a traumatic injury who has a respiratory arrest. And if you look at the AHA guidelines, they say that, definitely don't give too big of a tidal volume, don't ventilate too rapidly, and before you have a secure airway, think about doing 30 compressions to 2 breaths ratio. But none of that really helps you in the management of this patient who has a traumatic respiratory arrest. And so while they tell you a lot of doing, I don't think they help you think about the patient, and I don't think they necessarily help you think in a flow managed way. And so the PeRLS algorithm, the airway algorithm shown here, it's not meant to replace a difficult airway algorithm or otherwise, but it draws on all of those things. And it starts with, can you mask ventilate this patient, which is, I think, where all of us begin. And it thinks about how do we think about that? And then what do? We prepare to intubate, or we prepare to put in an LMA. And then we move down the algorithm from there. And if the airway gets difficult, we know that we're going to move down a difficult airway algorithm. And so this is where I think that ACLS doesn't give you the complete picture in the management of this patient. Another example is the patient who is in the operating room who becomes acutely hypotensive. Most of the ACLS data is guided from what do you do once the patient has arrested. We do CPR, we give epinephrine. But there aren't really data in the ACLS algorithm to think about what do we do before they arrest. In fact, when AHA talks about the peri-arrest period, they mean after you get return to spontaneous circulation. What do you do? Peri-arrest meaning post-arrest. And hopefully we never get to the arrest period. And you can see this in the data that they cite. For example, this paper that looks at a higher MAP versus a regular MAP after a return to spontaneous circulation, not improving outcomes, and the recommendations around targeting a normal MAP. And contrast that with the PeRLS algorithm that starts here at the top left with recognizing that the patient is hypotensive and then thinking about, is this a cardiogenic shock state or is this a hypovolemic or distributive shock state, moving down to thinking about volume resuscitation, to thinking about inotropes and vasopressors. We'll come back to this algorithm right now, but hopefully you can see that this is a preemptive management strategy that it has you both thinking and doing at the same time. And so putting this all together, I think that PeRLS is about avoiding ACLS. It is about doing stepwise solutions, not just one thing at a time. And it is about thinking about leveraging the skill sets that you all have, including advanced airway skills, and then how to think and act simultaneously. Now, because we're in Texas, I felt like I had to have a Chuck Norris joke in the talk. If there are trainees in the room, do you know who Chuck Norris is? Because I was concerned that you probably don't. The problem when you get old is you realize none of your jokes land anymore. But I transformed this for the lecture today, which is that the anesthesiologist took the PeRLS course. The dummy is alive and well in San Antonio with his wife and 2 kids. So I want to talk a little bit about the problem with evidence, and this is not a problem that's unique to the AHA, but this manuscript looked at the evidence for the AHA recommendations. You can see that in 2015, the AHA made 174 recommendations. That was based on only 12 randomized controlled trials and 91 either case series, case reports, or expert opinions. You can see that very few of the recommendations are strong, the green or the red, the should or the do not. Most of them are you may or it is reasonable to do something. And this just highlights the challenge of the management of the data in this space. It's hard to do randomized controlled trials in resuscitation. When you look at how the AHA lays out evidence, again, on the left is your strength of the recommendation. So green is a strong yes, red is a strong no. And almost all of the recommendations I'm going to show you today are shades of yellow and orange. These are may or it's reasonable. On the right is the quality of the evidence. So we'd like to see everything in dark blue. That is high quality evidence. And unfortunately, most of what we get is expert opinion, case reports, low quality evidence. In fact, in this paper, 62% of the recommendations come out of that level C evidence. Not great. And the reason I say this is not because the AHA is doing something wrong, not because in PeRLS we're doing something wrong, but just to point out that a lot of what we're going to talk about today is our best idea of what to do. But that does not in any way mean that you can't do other things or that you shouldn't do other things based on your understanding of the patient and their physiology who is in front of you, because none of these studies are going to address the complexity of that individual patient. But also because this evidence reminds me of one of Dr. Moitra's favorite papers here, which is looking for randomized controlled trial evidence to support the use of parachutes when jumping out of airplanes, and recognizing that hard to find that evidence, hard to design that trial. And so, again, I'm going to bring up some topics. I'm going to bring up some suggestions, but this doesn't mean that this is the only way to do things. And I'm going to draw primarily from these 4 manuscripts. This is the 2020 AHA update, the 2023 focused update on the right, and then the 2 PeRLS manuscripts published in ANA in 2018. And there will be an upcoming update very shortly. All right, so talked a little bit about PeRLS, a little bit about why it is different than ACLS, but let's talk about what does the evidence say about what to do in resuscitation in 2025. And I'm going to start with CPR. And really what the evidence tells you is CPR is important and CPR done well is really important. And so what do I mean by that? Well, I'm going to start with another audience response question. If you came in late, you can go to anes25.cnf.io, or you can go to the app and go into today's session, this session, and then click on the QA polling link, and it'll take you to the same place. Oops, go back. There we go. Ooh. I like the struggle. So about 60% just right, a little more, about twice as much for too slow than too fast. I think I see people go too fast, but I'm curious. So let's look a little bit more at the data. So this is now a 20-year-old study that looked at in-hospital cardiac arrest, looked at the measurement from the defibrillation pads on the rate of chest compressions, and you can see that the majority of the patients were too slow. 60% were less than 100, 30% were in the really low range, and only 10% were in the 100 to 120 range where we'd want to be. Now, this is an older study before there was a lot of effort done on CPR rate, but a later study in 2012 looked at the optimal rate for CPR, so what do we really want to target, and the probability of return of spontaneous circulation recognizing that going too slow will not generate enough cardiac output, and going too fast will decrease diastolic filling time and not increase cardiac output. And you can see that they suggest a rate of 100 to 120 is probably optimal based on retrospective data for return of spontaneous circulation. In the manuscript, they actually make the conclusion that the rate should be 125 based on their interpretation of the data. Now, remember, this is ROSC data, not survival data, but still important. There was another study that came out around the same time, looked at in-hospital cardiac arrest, looked at what rate of CPR was being done and how was return of spontaneous circulation. And in this group, their mean rate was 140. People were like pushing. But they had an increase in return of spontaneous circulation rate at the rate of 120 to 140. And it's interesting because talking to my European colleagues, even though the recommendations between the European Society and the American Heart Association are the same, the 100 to 120 rate, they tend to err on the higher end. And I see often we are targeting a goal of 100. In fact, for all of my Taylor Swift fans in the audience, new album came out on my birthday. New song Wood is a rate of 100. So if you need a new CPR song, you can be current today. Now, the problem with measuring CPR rate and looking at outcomes is rate is not an independent factor, right? We have to think about the depth of CPR as well as the rate. And so this is one of the earlier studies that looked at recorded depth in a large database study based on the kind of ZOL data. And they showed, you can see kind of a messy distribution of depth of chest compressions here. When this data is smoothed out and looked at probability of survival, you can see that somewhere in this 4 to 6 centimeter, 2 to 2.5 inch range seems to be optimal for survival. And again, as a reminder, this is because we would like 100% cardiac output, but with CPR, we don't get 100% cardiac output. In fact, data from the 90s showed that even with pretty good CPR, we might get 15, 20, 25% of cardiac output. And so it is pretty critical to do as well as we can because there's not a lot of margin for error. Now, I really like this paper from JAMA Cardiology, which looked at trying to map chest compression rate and depth together for output. And so this is kind of a heat map where the redder the color, the higher the survival rate. And you can see rate on the kind of y-axis, depth on the x-axis, and you can see that they settled out on a rate of 107 and a depth of 4.7. And that has been echoed now both in the 2015, the 2020, and then the 23 update of ACLS, which says that compressing at a rate of 100 to 120 is still the right way to go, that targeting a 2-inch compression depth and a maximum of 2.4 inches to prevent, 1, not allowing the heart to fully fill, and 2, damage like rib fractures. And so putting together CPR best practices, doing it well and doing it right, is starting CPR right away, and that includes in the OR if you're not sure what's going on, minimizing interruptions and chest compressions. I'm going to come back to this when I talk about echo. Doing a rate of 100 to 120 and a depth of 2 to 2.4 inches, allowing full chest recoil, which is one of the challenges that I see often when our aggressive interns are doing CPR, and then avoiding aggressive ventilation, I'm going to talk about in a minute. But I also think it's important to recognize that CPR is a lot of work, and for any of you who've done it recently, it seems to get harder every time I do it. This study looked at giving people a visual reminder of how fast they should be doing chest compressions and showed that while they were able to maintain the proper rate, their depth declined over time. And you can see that at 90 seconds, the depth gets pretty shallow. Interestingly, there was a medical student study out of China that did the same thing. You think medical students are super motivated to do the right thing, and even in a sim lab, they were not able to maintain optimal CPR over a long period of time. And so where I think we provide value as anesthesiologists in the room is being able to remind people to change CPR rotators. I am surprised at how often we see people persist at doing CPR for a long period of time, and getting people to switch every 2 minutes adds a tremendous value because we will optimize our CPR, which will optimize both return of spontaneous circulation and survival opportunities. But this also brings up the natural question, which is if humans aren't very good at maintaining CPR for a long period of time, maybe we should just put a machine on everyone, let the machine do CPR, and then we would be better. This is the LINK trial that looked at using mechanical CPR versus human CPR, and it failed to show a benefit for either return of spontaneous circulation or survival, including survival out to 6 months with a CPC, a cerebral performance category score of 1 or 2. This was done again in the paramedic trial, looking at the second generation Lucas compression device. Again, no difference in return to spontaneous circulation, no difference in surviving the event. Interestingly, in this trial, only 985 patients that were assigned to get the Lucas device actually got it out of the 1652 were assigned, suggesting that this device isn't as easy to put on as it might seem, and definitely for anybody who's used it, it can be a real challenge, particularly if you're not familiar with it. And then, of course, because we love meta-analysis, we had to do a meta-analysis of these 2 trials plus one other small trial. And you can see here in the top, this is survival to discharge. Survival to discharge here, no difference. Survived the event, no difference. And survived with a cerebral performance category score of 1 to 2, no difference. And so my takeaway from this man versus machine argument is actually that it probably doesn't matter, but using something that will enable you to get high quality CPR is the right thing to do, and the AHA says the same thing. In settings where you can't deliver high quality CPR manually, then consider using machine, but otherwise the CPR is the important thing, not the device in which you're delivering it. Okay, so we know that if a patient has a cardiac arrest, they need CPR, but what about oxygenation and ventilation, our home territory? I think that this is an interesting story that started with this porcine study in the 90s and some earlier work before that, but this was one of the first studies to show that just doing CPR without ventilating the pig in this case didn't change outcomes. So no change in return to spontaneous circulation, no change in 24-hour or 48-hour survival for the pig. Presumably this is because of what they showed here by tracing the aorta, which is that the more often you're interrupting CPR to do ventilation, the worse your coronary diastolic blood pressure is going to fall to, and the less likely you are to get the heart to restart. But interestingly, this paper looked at a hemorrhagic model of shock and made kind of another observation, which is just that maybe the positive pressure ventilation itself is changing the intrathoracic pressure dynamics in a way that negatively impacts your ability to get return to spontaneous circulation. So drawing your attention to the right side of this screen, you'll see kind of a Kaplan-Meier-esque curve here. These solid dots across the top are pigs in a hemorrhagic shock model that were ventilated with 0 PEEP. That kills me as an intensivist to say. Respiratory rate of 14. The open circles here had a PEEP of 5 and a respiratory rate of 28, and the triangles had a PEEP of 5 and a respiratory rate of 14. And you can see on the left that the differences were primarily during that kind of hemorrhagic portion of the case. They resolved when you got fluid resuscitated. But thinking about when we know somebody is hypovolemic and we are thinking about doing CPR, maybe we should be even more thoughtful about our ventilation strategy. And then the question comes naturally from that, well, is the problem really the intrathoracic pressure changes, or is it just that you are hyperventilating the pig, and therefore the pig gets hypocapnic, gets alkalemic, has cerebral blood flow problems, and then doesn't wake up? And so this study did an interesting thing, which is to have 3 arms. The first arm is a respiratory rate of 12, shown on the left. The second is a respiratory rate of 30. And then a respiratory rate of 30, shown here, where they added back CO2 to the pig. So essentially saying, hey, we're going to try to separate out the hypocarbia from the respiratory rate. And in this work, they showed that the survival deficit persists even when you add back the CO2, suggesting that the primary effect is the intrathoracic perturbations, not necessarily the hypocarbia. Around this same time, we noticed that bystander CPR was abysmal across the world. And if anybody's thought about it, doing rescue breaths on a stranger, even before COVID, didn't sound that fun. This was the first study to look at just doing chest compressions versus chest compressions plus ventilation, and showing that there was no difference in return of spontaneous circulation and no difference in survival. I want to make a point to say this is not true in pediatric literature. Peds are overrepresented in respiratory arrests by a long shot, and therefore need to have that taken into account in their resuscitation. But this is the early kind of beginning of this idea that to do hands-only CPR or CPR without ventilation. But I think it's interesting to think about the intrathoracic dynamics as we think about hands-only CPR potentially in some of our intraoperative cases. And so putting this all together, I would say if the problem is cardiac arrest, the patient needs CPR. If the problem is that they had a respiratory arrest, and you know they had a respiratory arrest because you were sitting there with them in the operating room, then you still should think about intubation or an LMA placement. And oxygenation matters, but probably over-ventilating patients is a negative thing. So we're going to move on from CPR and talk a little bit about medications in the management of cardiopulmonary resuscitation. And epinephrine still is kind of the king in this setting. Interesting, Cliff Calloway wrote this paper in 2013, now it's a little over 10 years ago, calling into question, like, is epinephrine doing the thing that we think it is doing? Now, one of my favorite questions to ask the fellows is, like, why do we give epinephrine in cardiac arrest? And a lot of times, the answer is, well, we want to restart the heart. I say, well, yeah, but what are we doing? They're like, well, it's providing beta agonism, it's going to stimulate the heart, and the heart's going to beat better. Presumably, what is actually happening is that we are using the alpha effects of epinephrine to raise coronary perfusion, raise aortic diastolic perfusion, to provide coronary perfusion to allow the heart to restart because it's no longer ischemic. And what's interestingly in this kind of systematic review is calling into question all of these other, or pulling up all of these other studies that show that epinephrine shows this early benefit. Like, it gets ROSC better than placebo, but it doesn't improve outcomes longer term compared to placebo. My hypothesis here is that maybe epinephrine raises the coronary perfusion pressure to get the heart restarted, but it worsens organ perfusion long-term after you get ROSC, and maybe that causes a problem. And this was one of the arguments now 10 years ago to think about vasopressin. So maybe we could use vasopressin instead, because vasopressin would raise aortic pressure, would raise coronary perfusion pressure, but wouldn't have the negative consequences on the heart longer term. And unfortunately, like, this story has been written. It's been 10 years. All of these studies, meta-analysis of vasopressin and return to spontaneous circulation didn't work. Hospital discharge didn't work. Neurologic outcomes didn't work. And maybe if you were, like, using my hypothesis and thinking, well, if we give the vasopressin early, then the vasopressin will work better than the epinephrine because it's going to get the early benefit and not the late downside. And unfortunately, on the early part, like, it's even worse. So that clearly didn't do it. And this was kind of the nail in the coffin for vasopressin in cardiac arrest. Now, the AHA went on to remove vasopressin from the ACLS algorithm, and they're careful here to say it's not because vasopressin was worse, because it wasn't. It just wasn't better, and it was confusing. And I will say I was like a fellow during this period of time, and you went to a code and it was like some people gave vasopressin and some people gave epinephrine, and like it was, nobody knew what to do. And so I appreciate their thought at, like, let's target the kind of right, let's target consistency in our management here. But I also want to bring up the point that I made earlier, which is that if you think your patient is going to benefit from vasopressin, it is a reasonable treatment for that patient, right? If your patient has pulmonary hypertension and you think in their cardiac arrest, I'm going to raise systemic vascular resistance without raising pulmonary vascular resistance by using vasopressin, I want to give 40 units of vasopressin instead of a milligram of epinephrine. I think that is a totally reasonable thing to do, and I don't think they would argue with you in that setting. So in general, I don't reach for vasopressin first, but there might be certain situations where you would want to. Now, I'm only going to show this slide for a second because I still can't figure out this study, but this was a study looking at combining vasopressin, epinephrine, and steroids, and it showed this magical, tremendous survival benefit in cardiac arrests. Unfortunately, in 2021, the subsequent study failed to show any of that benefit. And so it really called into question what happened in that first trial, and we don't, I think, still know, but the kind of conversation closed on this idea that it probably wasn't ready for prime time to do this combination of vasopressin and steroids, and right around the same time they removed vasopressin from the algorithm anyway. And so the idea was, hey, sure, you can use vasopressin, sure, you can use steroids if you think those things are indicated, but that's not going to be part of our standard management of cardiopulmonary resuscitation. And to simplify things, the AHA says, hey, actually, we just want to see epinephrine in the management of cardiac arrest. So in 2023, they added a line about calcium. And so I wanted to ask the group, how often do you see calcium being given in your kind of non-specific cardiac arrest cases? This is not where you know the patient's hyperkalemic and you're giving calcium. Good distribution. So like 40%, the majority, not that often, but 60%, like spread over kind of the 25 to 50, 50, or 100% of the time. 20% of people see it given 100% of the time. And I think that's like my observation as well. And what's interesting about that is looking at the data. So there are 3 randomized controlled trials looking at calcium and cardiac arrest. There are 8 observational, both in hospital and out of hospital cardiac arrest papers on this topic. I think the best one came out recently, which looked at around 300 patients out of hospital cardiac arrest, randomized them to get 2 doses of calcium versus just a saline placebo. This is the visual abstract from JAMA. And their outcome was sustained return of spontaneous circulation. And you can see in the calcium group, that was 19% of the patients versus 27% of the patients in the placebo group. Like, not a great argument for calcium, right? What about sodium bicarbonate? How often do you see sodium bicarbonate given? If you're a cardiac anesthesiologist, maybe you just don't answer because I know what you're going to say. Again, like a really broad distribution, like almost even across the board, with a weighted towards above half of the time. So this study came out in 2017. It was done in Prague. It was an observational retrospective study, but they did what I consider to be pretty impressive propensity matching as well as risk adjustments to look at the benefit of sodium bicarbonate in pre-hospital use. And you can see like all of the lines favor not bicarbonate. So this is where I talk to my fellows that like we all might feel that bicarbonate works. We might have all felt that bicarbonate works. Feelings are not evidence. This doesn't mean you can't give bicarbonate in a cardiac arrest. There are times where you know that it is something that is going to benefit your patient, but the evidence doesn't support its routine use in cardiopulmonary resuscitation. So both calcium and bicarb are listed as not being given. My theories on both of these, since I have a captive audience, my theory on calcium is that we know that calcium raises blood pressure. We know that it causes improved inotropy, but we also know that it sacrifices lusitropy. And so my theory is that if we're giving it during cardiac arrest, maybe we get ROSC, but then maybe we have a stiffer, less compliant heart that's not able to maintain stroke volume and adequate perfusion. My theory on bicarbonate, which has a little more evidence behind it, is that we know if we have a whole bunch of protons floating around and we give sodium bicarbonate, we'll end up with carbonic acid. We know that carbonic acid can cross cell membranes. We know that therefore as it crosses cell membranes, it dissociates and you get intracellular acidosis at the expense of extracellular acidosis. So maybe for some of our patients, we're pushing the acid intracellular, including into neurons where we don't want it to be, and that causes long-term consequences. And so maybe I've convinced you to speak up in the next code when you think about calcium or bicarb, or at least be using them for specific indications. Another plug about PeRLS here, where some of these concepts are discussed. And then I'm going to move to talk about defibrillation. So if we're talking about defibrillation, we're talking about ventricular fibrillation, pulseless ventricular tachycardia. And not much has changed in this space. The goal is that if you see a shockable rhythm, that we should defibrillate the patient, then we should do CPR right after. But I do think there's something that's coming down the pike, and so I wanted to bring it up, and that is both double sequential and then vector change defibrillation. And there are, I think, at least 2 trials that I know of enrolling right now to look at this. This trial was started in 2022. It was an out-of-hospital cardiac arrest trial. They randomized patients to either get standard defibrillation if they had a shockable rhythm, to get double sequential defibrillation, meaning 2 defibrillators applied, shock both. Or vector change, which is just putting the pads anterior-posterior instead of anterior-lateral. And you can see this trial was stopped because of COVID, but you can see that the outcomes were better in the double sequential and then the vector change groups. Now, the AHA and my interpretation is like, this is insufficient evidence for me to support using either of those strategies right now. But I do think that there's going to be some discussion about this. And I will say, having lived in Ohio for 10 years, there's some patients where 2 defibrillators on their size body seems like it probably is closer to 1 defibrillator in the now California bodies that I take care of. And so I wonder if, as we explore these groups a little bit more and we think about refractory fibrillatory arrest, maybe there's going to be benefits to these other strategies. So this is really to park in the back of your mind as I might see this coming in the future. And I also want to bring up the point that it is reasonable in any fibrillatory arrest to hold off on the epinephrine to give the shock, right? We want to give epinephrine to raise aortic pressure to get reperfusion, but if we can get reperfusion with electricity, that maybe avoids the downstream consequences of epinephrine. Another plug for PeRLS. I want to briefly comment on echocardiography during resuscitation. So this paper is 20 years old, like 20 years ago, still talking about echo during resuscitation. And what I think is new in this space now is this idea of pseudo-PEA that we're starting to recognize more and more, and you're seeing it in published trials. Pseudo-PEA, for those who haven't thought about this, you've got, normal blood pressure over here. You've got palpable pulse and hypotension. And then you've got what looks like a narrow complex sinus rhythm, but you put the echo probe on and you see that the heart is squeezing even though you can't feel a pulse. That is pseudo-PEA. So PEA, where the heart is still actually moving, it's just not moving enough to generate a pulse or a blood pressure. Then of course PEA is, you see the electricity, the heart's not moving at all, and then asystole, you see neither of those. The reason I bring this up is there is suggestion that pseudo-PEA might be a different kind of subset of cardiac arrest than PEA or asystole. And so I think that as we move forward, we may see this category emerge and offer different treatment options. And I think that a lot of our patients in the perioperative setting may fall into that category. And so this is also to kind of plug in the back of your mind as like this pseudo-PEA concept may be coming back in the future years. Now, in terms of outcomes, there are only 2 decent randomized trials looking at ultrasound during resuscitation. One of them showed a benefit in ROSC. Neither of them showed a benefit in survival or neurologic outcomes. And I think the big problem with echo, and I was at a talk by Ollie Panzer from HSS who talked about this. The problem is that when we roll the echo machine in the room, everybody's eyes go to the screen or to the person doing the echo. And everybody who's doing the echo just wants 1 more minute to get the perfect view before you restart CPR. And in both of these trials, they showed that like CPR interruptions were more common. And so the best way to do this that I have seen is to have somebody count down for your pulse check, like 10, 9, 8. Then the pulse check starts. The person doing the echo is recording the loop. Somebody else is controlling the timer on checking the pulse. The screen is turned away from everybody, so nobody can look at it. And then once CPR is restarted, somebody is interpreting the recorded loop. And so far, that's the best strategy that I've seen for the use of echo in the setting of resuscitation, because otherwise I think it just becomes a distraction that doesn't offer any benefit, and it is something that gets in the way of CPR, which we know has benefit. So I'm going to talk about eCPR. I know not everybody here is at an ECMO center. By eCPR in this context, I'm meaning veno-arterial ECMO that is instituted during or around a cardiac arrest. The goal for eCPR is to recognize that maybe we have a reversible cause of the cardiac arrest, But even if we do, we know that the organs are going to suffer. And so we're going to put the patient on ECMO to perfuse all of the organs, kidney, heart, liver, brain, while we fix and continue to fix the underlying problem. And early CPR data was all, not surprisingly, observational. But there are two trials that are recent that I think are moving the needle on this conversation. The first is the ARREST study. This is out of Minnesota. Minnesota has an incredibly well-integrated pre-hospital system, kind of mirrored after some of the centers in Europe. They enrolled 30 patients in this trial, randomizing them to ECMO versus standard ACLS, and it was stopped early because of the profound survival benefit in the ECMO group. Now, I would caution everyone to recognize this is a system solution, that it works very well. This does not mean that you could just run out and start putting patients on ECMO and expect them to do as well as they were doing here. I know personally that this group has an incredible amount of work put into the system that has built this. The hyperinvasive trial did a similar intervention at transporting patients early during cardiac arrest to an ECMO center to get them on ECMO. You can see a primary survival benefit here of 31% in the ECMO group versus 22% not statistically significant. But I think that this really calls into question like where eCPR is going, and there are a lot of centers around the country, including at Stanford, Melissa Vogelsong's work, looking at where is ECMO going to go in the realm of resuscitation? Is it going to be a pre-hospital, in-hospital intervention? Who are the patients that benefit? And how do you build systems that provide this very complex, very expensive care to patients? And so what the ACLS, or what the AHA says here is that it is reasonable to do eCPR if you are thinking about a specific subgroup of patients and building a system around it. All right, so we do all of this work. We get return of spontaneous circulation. If you're the anesthesiologist in the room, you're like, yes, and I want to get them out of the OR as fast as possible so the ICU can deal with them. Totally reasonable. But let's talk briefly about what we will do as they go to the ICU, because sometimes that impacts how we think about the patient in the operating room. And the first is these trials that came out in 2002. And these are, I think in my mind, they stand out as two trials that move the needle faster on clinical care than any trials in kind of my time, which is this studies that targeted temperature management study that looked at hypothermia versus not after cardiac arrest and showed a benefit to survival and to neurologic injury. And a pretty impressive survival. And very quickly, everybody said we should be making everyone hypothermic after a cardiac arrest. Reminder, these are patients who have ROSC but who don't wake up. So comatose patients, if they wake up, this is not for them. And the challenge in looking at that study, you can see the 38 red line here is fever, right? And the normothermia group, like lots of those patients have fevers. And so the criticism that came out after the fact, after we'd started making everyone hypothermic, was like, actually, this was a fever versus hypothermia trial, not a normothermia versus hypothermia trial. And so that enlisted the two subsequent studies, the Targeted Temperature Management 2 trial. Again, you can see the fever line there in bright red, and you can see that these patients in the control group did not have fever. And you can see that the survival groups look much more similar. The benefit went away. Capital Chill, what a great name for a study. Capital Chill looked at mild versus moderate hypothermia. Again, no substantial difference when you look at the survival benefits here. And so where are we left? Well, if I have a patient in the OR who arrests, I can definitely feel like I can take the bear hugger off. I don't need to actively warm them up, but I also don't want them down at 31, particularly if they're bleeding. And the way the AHA phrased this, which I actually think is a thoughtful approach, right, is saying that if a patient is comatose after ROSC, we want to control their temperature. We know that fever for the injured brain is really bad. We don't know what the right temperature is. We know that fever is bad. We know that too cold is bad. Somewhere in the middle is reasonable, and it probably means that your hospital or your practice has to build a system around deciding how you're going to manage that patient's temperature and what temperature you're going to pick, and we're not going to interfere in that. All right, hopefully nobody has to make this decision, but when are we going to stop CPR? And this is something that has come up more and more as we get more and more of these devices that can keep people alive for a long period of time. The Lucas device, for example, never gets tired. And we know that in CPR time is organ function, and you can see here that both in shockable, the top line, the red line, in unshockable rhythms, that after about 30 minutes, your cumulative survival flattens out pretty good. So if you are running a code and it has been more than 30 minutes, the likelihood that you're getting additional benefit at that point is declining. Now, there hasn't been enough data to say how do we really identify when we're done. But one area that we do know pretty well, and this is pre-hospital data, so less relevant probably to our practice, but this is the termination of resuscitation algorithm in the updated in the 2020 guideline, which said that if you had an arrest out of hospital that was not witnessed, they didn't get CPR, they didn't get return to spontaneous circulation before transport, and they didn't have a shockable rhythm, that is somebody who is not going to do well, and it would be reasonable to stop CPR at that point. And that is because the abysmal outcomes in non-shockable rhythm adults who didn't get bystander CPR. Another plug for PeRLS. All right, so let's pivot and talk about the evidence for in-hospital cardiac arrest and recognize that if your hospital looks at all like my hospital, there are some patients in our hospital who, if they code, I don't know that survival from that code would be a benefit to them. They are in a bad way before, and doing a resuscitation is probably not in their best interest, and we talked to them about that. We also know that even if we did all the things, we are not going to be able to get 100% survival with this subpopulation that is sick because they're in the hospital. So looking at Ramachandran's paper from 2013 and looking at the perioperative situation compared to the inpatients, there is some good news. So if you look at both operating room PACU and ICU codes, survival is substantially better than your general inpatient. My theory here is because this is often, we know why someone arrests, and we were able to intervene very early in the process. And indeed, in this paper, they showed a shorter time to epinephrine and a shorter time to invasive airway placement. Not surprising. We also know from the NISQIP data that 1 in 200 surgical patients are going to have a cardiac arrest. About half of those are going to be within 5 days of surgery, and these are all sick patients at baseline. 93% of them are ASA status of 3, 4, or 5. And so when we're thinking again about ACLS, we're going to think and pivot to PeRLS because we're going to think about how do we manage this patient in the perioperative setting, because that is where we all live and also where the outcomes are really quite good. And what is different about this population is that we can avoid ACLS. We can use anesthesia-specific algorithms. And we're going to talk about some of those examples now. So these are not audience response questions coming up, but you can just shout out an answer and I will repeat it. What is the most common cause of perioperative cardiac arrest in patients having abdominal surgery? Pneumoperitoneum? What else? Hypovolemia? Yeah, interestingly, and this is not perfect data, but it's sepsis. Okay, distributed shock combo there. Looking at the PeRLS algorithm, this is where, again, starting at the top left, patient's hypotensive. We can assess their cardiac function, see if they need volume. We can give blood or volume. We can see how the function of the LV is. If the function is not good, we can consider an inotrope. If the function is good and they're still hypotensive, we can add a vasopressor. And so this gets us through most of the management of sepsis from a perioperative perspective. What about if you have a gynecologic or urologic surgical patient? Why do they arrest? PE, sepsis, what else? Hemorrhage, the Verey's needle into the aorta does it. Interestingly, bradyarrhythmia is common. And so when we look at the PeRLS algorithm for bradycardia, this is one of my favorites because this really highlights the ability to think and act at the same time. So this says, hey, could this be autopeep? Could this be hypovolemia? Could this be an air embolism? Could this be a high spinal? And then it talks about giving 0.5 milligram of atropine if the patient is hypotensive and bradycardic, giving 1 milligram of atropine if the patient is arrested in bradycardic. And then if you are doing CPR and things are not getting better, then moving on to what we'll show you in a minute is the comprehensive algorithm to think about ongoing management. Compare that again to bradycardia and the ACLS algorithm, which says like, hey, you should think about the reversible causes. Like, doesn't give you the list. And what we're starting to see is now that AHA is putting together flow type diagrams for all of their algorithms that are above and beyond their initial recommendations, which is really them borrowing from what we are doing in PeRLS, which I think is a step in the right direction. Just to point out the tachycardia algorithm here, again, gives you opportunities to see what are the things that you should be thinking about and considering. Giving drugs like amiodarone, calcium, and lidocaine, and I like that this list is simplified, because when you look at the AHA algorithm, over here on the left, they talk about giving procainamide, sotalol, like medications I think most of us are not comfortable giving on a routine basis. But most of us are pretty good about giving lidocaine and about giving amiodarone. Also, they say like, oh yeah, and by the way, if that doesn't work, call an expert. Like that also is not the most helpful recommendation. But to their credit, like they do come around to, at least for Torsade, giving, or polymorphic VT, giving lidocaine, amiodarone, and other measures like we mentioned, and then giving amiodarone for unstable atrial fibrillation, shown here. So what about for the cardiac anesthesiologist in the room? Why do cardiac patients have cardiac arrest? I know it's a lot of cardiac. Yeah, ischemia. So when we look at the RV shock algorithm for PeRLS, again, we start at the top with hypotension. We look at the echo, and then think about, is this patient going to be volume responsive? Do they need blood or fluid? If they're not going to be volume responsive, then do they need an inotrope? If they are still hypotensive, do they need a vasopressor? And then relatively quickly, do we move on to mechanical circulatory support? What about ENT patients? Airway, yeah, brilliant. Hypoxia. And we went through this algorithm earlier to talk about intubation during CPR, but I wanted to draw the point here that this algorithm calls for a potential hold in CPR to place the airway. Now that seems weird, because I was telling you at the beginning how important CPR is. But if you know that your patient had a respiratory arrest, then treat the respiratory problem, because that is probably going to be the thing that makes the difference, not necessarily the CPR. A quick plug to recognize that the cardiac arrest presents differently in the operating room. So most of the time we will see an aberrant rhythm on the EKG. We will lose end-tidal CO2. We will see a change in the pulse oximetry, and then maybe we'll see the EKG leads go away. But when we put this all together into the comprehensive algorithm here, this is calling for help, starting CPR, avoiding hyperventilation, thinking about some things that this could be. If this is a shockable rhythm, giving a shock. If this is not, giving epinephrine, considering ECMO if you're at an ECMO center. And fundamentally, I think this is a different look than, hey, hey, you should give a shock or give some epinephrine in this algorithm. The last point I wanted to make is there are a lot of causes of perioperative cardiac arrest that we see that almost nobody else in the hospital sees, and PeRLS addresses all of these in kind of special conditions. There are 8 of them, and this is growing. This is anaphylaxis, LAST, MH, and all of these are mentioned in the paper, and many of them will be mentioned in the updated manuscript. They give you insight into how do you manage all of these problems, and obviously there are talks on all of these across the meeting, so I'm not going to go into them. Do you want to make a plug to say that our update on the PeRLS algorithm is with the publisher and will be coming out soon? I think there are some good incorporations of new data, but also some streamlining of the algorithms that you'll see. And so my final question for you, maybe, a weighted question. Do you feel better about your ability to manage perioperative cardiac arrest? See, I learned as program director, if you ask the right questions, you always get the right answers. So hopefully you're doing better than these two. And I want to leave a little bit of time for questions. I want to thank my new Stanford Critical Care family, my family, and my wife who is solo parenting while I'm here. And I'm happy to take any questions. Please. Yeah, if you could use the microphone for questions just for the recording.
Okay. So question for you. In our hospital, like most ACLS is required for all the anesthesiologists. And, that's always troubled me because, again, this makes a lot more sense. Would you recommend administratively making a shift to get everyone to do PeRLS, who is an anesthesiologist, and changing our medical staff bylaws?
I would. So we have that opportunity at Stanford. So at Stanford, you can take ACLS, PALS, or PeRLS as an anesthesiologist for your certification. I think it's a lot more relevant to what we do every day. I think it's easier to access. Most of the faculty have been really happy about it. When I was at Ohio State, what we were able to do is to say, hey, your first credentialing at the hospital has to be ACLS, but all of your subsequent, every year or 2 years, could be PeRLS after that. And I think that was another way to approach it. But I think thinking about, is this a medical staff bylaws issue? Is this a credentialing issue? And then reach out to come talk to our team, because we have other example institutions that have been able to do this, and we're happy to give you that supporting information.
John Charnan, Mayo Clinic. Thanks for brilliant talk. 2 questions.
Okay.
Hospital beds have a CPR mode,
Yeah.
so that they can be flat and any fluffiness of the bed is taken away. Do you think anesthesia machines should have an arrest mode?
Ooh.
And then if you did, would you program zero PEEP, or what would your mode be for an arrest mode?
Oh man, that's a fun question. I love the idea of having a mode like an easy button. I think I probably would program zero PEEP because it would help you exclude auto PEEP and other diagnoses. My concern would be if you have the ARDS patient who is easily de-recruitable, how would you know not to push that button to not compound your arrest problem? But I suspect more often than not, it would actually be helpful. Cool idea.
Can you comment on the optimal dose of epinephrine? A few years ago, they were saying use less.
Yeah.
And also possibly the role of intralipids. A few years ago, they thought it might be helpful.
Definitely. So I think that for standard undifferentiated cardiac arrest, the majority of the opinion is 1 milligram is still the right dose of epinephrine. I think that for other types of cardiac arrest, dose adjustments is very reasonable. So, for example, in the case of local anesthetic systemic toxicity, considering a dose in the kind of 100 mic, 200 mic, 300 mic range would be a reasonable kind of code dose. Definitely giving intralipid. I think even though we don't have randomized controlled trial data, now we have a preponderance of case report, case series, and other expert opinion to suggest a benefit from intralipid in last. Similarly, for anaphylaxis, I think it is very reasonable to start with a 10, 50, 100 mic IV dose of epinephrine to see if you get a response before jumping to 1 milligram doses. Anybody who's had or seen the administration of an EpiPen, you often get a very hypertensive patient with a full milligram dose in the setting of anaphylaxis.
Hi, Dr. Stahl. Hi, Dr. Stahl. Great presentation. Can you comment on actual patient positioning for better neurological outcomes? Because there is some controversy about keeping patients flat when you do chest compressions, whether or not they're getting enough venous drainage. And I mean, the whole point of doing CPR is for patients to actually survive to hospital discharge functioning. And what are the future directions on that?
Yeah, great question. So what I'll say, the data that we know now is that, or the recommendation now is still supine for the majority of patients. Where I'll say there are differences is that if the patient is already prone, it would be very reasonable to leave them prone and do CPR in the prone position, which is relatively new. There are also case reports of doing CPR in the lateral position for lateral patients. For obstetric patients, we know that whereas the guidelines used to suggest turning the patient laterally or tilting the bed, that it is really hard to actually move the gravid uterus in that way. And so leaving them supine but manually displacing the uterus is the way to go. And that data is where I struggle with some of this kind of early case report series about how should we position the patient, because if tilting the bed doesn't help the gravid uterus, I'm not sure it's going to help in other CPR situations. I also worry about and have seen as the bed moves, we know that the heart moves out from under the sternum. And so I think anytime we look at changes in position with CPR, we also then have to look at the effectiveness of the CPR and make sure that we're not improving venous return and then worsening our ability to compress the right ventricle with the CPR. And so I'd like to see more studies that kind of combine those two ideas, similar to what we saw in the depth and rate article. Thank you guys all for being here. I really appreciate it.